Again, thank you, Venky, and it's an honor to be here. I'm a big fan of AI, but the titles of my talk got thrown into AI and twisted like a pretzel, so this is what we're going to work off of. Here's some possible disclosures. What the hybrid air is going to be in, I have no idea. I mean, I can't predict, I barely remember some of the past, must predict in the future. 9 years is a long time. You kidding me? We hope it's going to be a lot better and a lot different. Hopefully we're not going to go backwards. That's not a good idea either. We know it's going to be disruptive, and that's good. AI is going to be part of it, more and more of it, every day as we go along, doing the same thing that we don't think works well over and over again. It's not really going to get us very far. We need to be innovative, and I got some beefs with industry on that, which I can talk about later. So what is hybrid? Well, it's the integration of open and endovascular. It can be done single versus stage procedures, and the only real devices that we have that we call hybrid devices is the frozen elephant trunk, the Thoraflex. It's available. So it combines open and endovascular repair. Initially it was for gravely ill patients, those unlikely to survive, unlikely to live very long, but it's moved far beyond that as we've already heard. So in this session we're supposed to be talking about the arch and the thoracoabdominal, so let's talk about the arch a little bit. There's an evidence gap. There's no randomized or controlled clinical trials comparing HR and open surgery. Dr. Provenza showed us some. The good thing about not having any data, you can fall back on philosophy and statistics. So, and why does this matter? Well, the treatment decisions are guided by anatomy. Dr. Provenza pointed that out. Patient risk, surgeon expertise, and the availability of what we have from a device standpoint. Despite increasing use of hybrid approaches, there's no really high-quality comparative evidence to exist to support one strategy over the other, particularly in arch aneurysms, but we are moving. These are the three original sort of descriptions of hybrid. All of them require a sternotomy, the first with debranching, the second replacing the ascending aorta and coming off of that, and then the so-called, basically the elephant trunk device. And then Chad Hughes came along and added, took it from 3 and turned it into 8. There's no sternotomy for the first 3, and these are the carotid subclavians, and then the endovascular grafts, single, double, multiple, etc. The fourth one coming across requires a sternotomy. It's debranching and then running a stent across the arch. The one on the lower left is placing a graft and coming off that, as I mentioned. And then the important part about these is to have a landing zone. And then finally, the elephant trunk graft. But we've got a lot of different tools in the chest. Dr. Provenza talked about the first one and shown there on the left, where we did a bunch of ascending dissections and put stent grafts down in the descending through the open arch. It made a big difference with regards to malperfusion, but there's a lot of other opportunities here. Zone 2 arch, the AMDS bare stent model, and then the Be Safer from the Cleveland Clinic. What do the guidelines say? Well, this is from the European guidelines, and creating a sufficient landing zone if you're going to do this, if you're working through the ascending aorta for later hybrid approaches, is extremely important and really assist in downstream repair. If you throw all these together, it basically says that if you've got suitable anatomy, even in high-risk patients, and even in some low-risk patients that are symptomatic in the proper setting, that hybrids or total endovascular are entirely appropriate. What about the no sternotomy approach? We mentioned these 3 earlier. These can be done with these carotid subclavians. We all have different techniques for this. I like to move the subclavian over to the carotid, and then Cerny then moves the carotid over to the innominate, but I'll use a carotid innominate artery bypass. But these can be done without a sternotomy, and in some patients who've had 3 or 4 sternotomies, it's quite useful. This is actually a patient, I think Dr. Provenza helped me with. This patient was not a candidate for an open operation. It had this previous TVAR. So what we did is we went in there, we're going to go back. We went in there and put in an Arise graft and a TBE graft. Both of them were actually under clinical trials at the same time, but we avoided a sternotomy doing that. This is a fellow with a large sternal plate that's eroded back into his transverse aortic arch. This guy is not a candidate for a sternotomy, so we went off the descending and branched all the vessels and then placed a stent graft across it. And after 8 years, the patient was doing well. So what about the sternotomy approach? I mentioned those earlier with the diagrams. You open the sternum and then you bypass the brachiocephalic vessels in one form or another, and they're just shown here in some of these diagrams. This is an operative photograph of that with a 3D CT reconstruction, and these can be done in various ways. But what the approach that we've been leaning towards more recently lately is to do the zone 2 with the branching of the left carotid, the innominate artery, and coming back with the TBE graft, which has been described. So this is a 71-year-old male. He had cirrhosis, portal hypertension, ascites. He's a terrible, terrible candidate. But we did go through a sternotomy. He's at a right-sided aortic arch. This is a little bit complicated, so I'm just going to tell you that what we did was we took this multi-branch graft and we sutured from the ascending aorta to the left subclavian, took the left carotid, sutured that to the graft separately, and then used bypasses to the right carotid into the right subclavian. So this just describes what we did, and this is what we ended up with. And so this is a sternotomy, but it avoids hypothermic circulatory arrest and all of the other issues. But this TBE approach to the landing zone is what we've been doing lately. Here's a patient that I operated on about 2 weeks ago this morning, and he had a type A dissection, and you can see the problems here. But he dissected his innominate artery, his left common carotid artery with occlusion, left subclavian artery, supramesenteric artery with occlusion, lost his right renal artery, and then went down into his right iliac artery and lost circulation to his left leg. So he had cerebral malperfusion, visceral malperfusion, renal malperfusion, peripheral malperfusion, and what we did was, well, this is his dissection. We used this this prefabricated branch graft for a landing zone, and this just describes how we did this, but we created a distal landing zone for a TBE later, and we came back and basically brought him from the operating room to the hybrid suite, put the TB in there, and then advanced, also placed a Cook graft down to extend it to the abdominal aorta. We opened up his supramesenteric artery, and also, I don't know if this will play, anyway, his leg opened up as well as his renal artery. As I mentioned, the only hybrid is the elephant trunk, and we have the Thoraflex. The results on this are good, but they're not great. This is from Ma from a couple of years ago. Zone 0 meta-analysis of over almost 10,000 hybrid repairs, 14% stroke and 10% mortality rate. This is kind of an interesting meta-analysis, but from GU, also John Elefrades is on there. The operative mortality rate was 8.5%, stroke was 3.5%. And the longer-term mortality actually favored the hybrid. This is a meta-analysis of hybrid and total arch, and there's mortality. There's a bit of a difference in neurologic with open versus hybrid, but actually wasn't statistically significant. The 3-year survival was about the same. Late complications are not uncommon. We're familiar with all of these. Let me just talk just a second about the thoracoabdominal aorta and hybrid. We adopted this and did some of these cases a number of years ago. Really don't do this much anymore. Instead of debranching the brachiocephalic vessels, we debranch the visceral vessels and put a stent graft all the way up and down, as you see here. There's also another hybrid version of thoracoabdominal, part open, part endovascular. Yeah, that's almost a separate subject. We then quit doing this for a while, partly because our experience, and here's from Milan, from Roberto Chiesa, the mortality rate, the spinal cord ischemia, pancreatitis, and the renal failure rates were just all too high. And this is from a study from 2012, basically showing the same thing: high mortality, et cetera, et cetera. And one of the things that we weren't seeing with open thoracoabdominals, but we were seeing with these debranched hybrids, is bowel ischemia was actually fairly high in our experience as well and in others. So it really deterred us from doing that. To complete this subject, though, Sabine Whipper has got this device with Terumo, where you go from the abdominal aorta up into the descending, deploy a graft like an elephant trunk in a reverse fashion, and then come down and debranch the brachiocephalic vessels. Some of this was done in the U.S., but I think this is on hold right now. In the efforts of time, I'm going to. But we're still going to need to keep our open skills for a while. These things are still going to have problems, and there's a group of patients, even in the future, that are going to need our technical experience. One of them's failed thoracoabdominal repair. Here's just one quick example. This patient had Marfan syndrome, had an extent 2 thoraco. He had a bental, and his arch was replaced. And And then because of that, he was on ECMO as he failed, then he had LVAD placement, and then he had ultimately an orthotopic heart transplant. He had TVAR with a left subclavian stent. He had chronic kidney disease, and he underwent a total endovascular thoracoabdominal aortic aneurysm repair. But it kept getting bigger. He refused more endovascular surgery. He was symptomatic. This thing looked to us like it was probably going to rupture. Took him to the OR. That's what we found. You can see there the graph as I took it out below, and this is always interesting to take these things out. They really don't make the redo open operation any easier, and this is the graph we put in there, and he's still doing fine. So the majority of complications may be managed with endovascular repair. We can deal with coils, plugs, occluders, and polymers. However, open surgery, even my partner Gustavo Odegrich agrees that infection, fistulas, enteric, esophageal, and aortic, some patients with rupture and aneurysm growth, despite multiple attempts at endovascular repair, are still going to have the opportunity to carry out an open operation when necessary. I don't have a crystal ball about the future, but I do admit that it's going to, in the future, we're going to have streamlining of our procedures, reduced cost, increased access, larger clinical trials, collaborative leadership, AI, working together with our interventional cardiologists, radiologists, vascular surgeons, as well as cardiac surgeons. A team is the only thing that's going to really make this work well. And so these are just some of my last thoughts. AI-driven planning and real-time imaging is in our future. Patient-specific custom grafts are going to continue to grow. Bioabsorbable and advanced bioengineered materials, robotic-assisted deployment, improved outcomes with lower stroke and mortality rates are hopefully in our future. Patient selection is going to remain critical. We're going to have a lot of different tools in the chest. Matching up the right patient with the right tool is going to continue to be one of our challenges. Thank you for your attention.